Good evening. My name is Jonathan George. I'm a nurse practitioner working in the emergency unit in Cardiff and Vale, in the University Hospital of Wales. I've been asked tonight to do a session on digital nerve injections. I'm going to try and make this as interactive as I can. We've got a couple of ground rules, so just make sure everyone's aware this is being recorded. If you don't want your face to appear in the recording, I advise you to turn your video off. If I can ask everyone to stay on mute unless you're speaking, just because this can interfere with interruptions during the session and could cause a bit of an echo. If you do want to speak, just press the space bar. It's a quick way to come off mute. There is a chat function, and Roz will be keeping an eye on the chat function. So if anyone has any questions you want to ask through the chat box, please do so. And we will aim to answer all the questions either as we go through or at the end. If you are struggling with reception at any point, just turning you off camera can help as well. At the end of this, everyone will receive a certificate. You just need to fill out an evaluation form and the certificate will be emailed. Okay, so tonight's session is about digital nerve injections. So this was something that we picked up in one of our previous feedbacks. So we're presenting this. By the end of the session, hopefully you'll have a bit of knowledge of indications of a digital nerve injection. We'll have recapped some relevant anatomy. There should be an understanding of relevant pharmacology, how to manage any adverse reactions, understand how to carry out the procedure. And at the end, we'll talk a little bit about how this skill can be assessed clinically in practice. And then there'll be a little quiz at the end for people as well. So, what is a digital nerve block? Anyone got any ideas? Feel free to pop it up on the chat or come off mute.
No questions yet, John.
Anyone got any ideas? So, digital nerve block, it's an injection of local anesthetic into the base of finger or toe, and it provides regional anesthesia for a patient. A little bit of background history. It was first described in 1889 for use of an ingrown toenail, and they used 20% cocaine injected into the toe. They moved on a little bit, not so much using cocaine anymore. Who could administer it? So who was within their scope of practice to administer a digital nerve block? What sort of job roles?
So Wall, G599, has put an AMP or an EMP.
Okay.
And,
anyone else?
And yeah, Bex Davey has put registered practitioner. And Sophie Greenacre has put anything competent. Anyone competent, sorry.
Fab. Those are good answers. So, anyone who's qualified to administer medication, so be qualified nurse, physiotherapist, paramedic, advanced practitioners, EMPs, ACPs, and doctors in the department can give them as well. So, indications for a block. Would anyone agree or disagree with these? We've got dislocation, lacerations, distal, nail bed injuries, paronychia, nail avulsions, and foreign bodies. I'll show you some pictures as well. So one of the things that registered nurses in the department can do, so if you've got sufficient staff for triage or for assessment, this can be administered while a patient is waiting before they go for x-ray. And in one of our previous departments, we had a PGD available for triage nurses to be able to administer blocks while the patient went off for x-ray and while they were waiting. So it's made the patient a lot more comfortable before they were seen by someone. We
got some questions, John.
Yeah.
Would it work as well with infection?
No. So you shouldn't be we'll come to it, but you shouldn't be injecting into an infected area. Lignicaine won't work in an infected area.
Right. There's another question.
Yeah.
Right. From Neil, he says, I sometimes feel that discomfort from a nerve block weighs the benefit in finger dislocation.
Okay, it's a good point. And there are other things that we can give as well. So we can use adjuncts, we can use Entonox, use distraction techniques in children as well. But if it's something that's going to be a prolonged procedure, especially if you've got a wound that needs to be looked at, it will make it a lot more comfortable for the patient. What are the contraindications? Can anyone tell me?
Right, allergies from Stacey. Infection.
Yeah.
Sophie says not always effective.
Okay.
That's it at the moment.
So allergy, local infection. So at the site where you're injecting, you wouldn't inject into infected area. Anyone who's got any compromised circulation where you might be concerned there's something else going on and you don't want to waste time, you just need to get that circulation back. You're not going to delay time by injecting.
Another question has come up. We'll answer patient refusal.
Yeah, good. So you need consent. If the patient hasn't consented, then you're assaulting the patient. So you need to have the patient's consent as well. So sometimes you will see lignicaine and adrenaline injections that are used for various other things. We don't use them for ring blocks. So we don't use them in fingers or toes. There's a high risk of developing ischemia and gangrene. Some tips: reduce discomfort for the patient. If you warm up the lignicaine in your hand, it makes it more comfortable for them. If you've got a similar needle and you're injecting slowly, it makes it more comfortable for the patient as well. Got a couple of complications. So infection, it's rare as long as you are using aseptic technique. So make sure that you've cleaned the area and you're following ANTT procedures. Risk of hematoma, smaller needles, make sure that you're not going into any superficial veins. Gangrene, it's a lot, the risk is reduced by not using anything with adrenaline in it. And nerve injury, it can happen, but it's very, very rare as well. Okay, anatomy. Can anyone tell me about some of the nerve anatomy of going down the finger? So what nerves have we got?
Karen's put radial, ulnar, and medium.
Okay. Any other nerves?
Dorsal digitalis.
Yeah.
From Darren.
What's up, B?
So every digit is innervated by 4 digital nerves. From the upper limb, they come from the median, ulnar, and radial nerves. From the lower limb, so don't forget that this can be used in feet as well as fingers, even though you've seen pictures of fingers. It comes from the tibial and peroneal nerves. And then you've got 2 in the palmar aspect and 2 in the dorsal aspect. And the palmar aspect comes down and innervates the palmar aspect of the finger and up into the nail bed. And the dorsal aspect gives you sensation along the dorsum of the finger. And there's a little picture for you. And here's another little picture. So as you can see, they're coming along the sides of the digits, top and bottom. Is there any other anatomy that we need to be aware of?
Emma's put arteries.
Yeah.
Darren's put tendons, and Karen's put vessels.
Okay. Anything else?
And Bex has put ligaments.
Mm-hmm.
And Aidan's put bone.
Yeah, good. Fab. Can anyone tell me what the bones of the fingers are called? On the screen for you now. So we've got our phalanges going down the fingers and going down the toes as well. And then we've got tendons coming along top and bottom. So we've got flexor and extensor tendons that we need to be aware of. And we've also got arteries and veins coming down the fingers. So anytime you're doing any procedure to a patient, you just need to make sure that you're aware of the relevant anatomy underneath. So most common drug that we use is Lignicaine. Can anyone tell me the dose of Lignicaine?
Bex has put 2%.
Okay. So Lignicaine comes in two strengths, 1% and 2%. Generally, we advise using 1% for ring blocks and for suturing. You can use 2%, but you've got to use a smaller volume, so you've got to adjust it.
Yeah, Darren's put 4 mils of 1%.
Okay. So we want to be injecting up to 3 milligrams per kilogram for your patient. But yeah, a couple of mils is going to be enough for a finger. It's a very small space that you've got to fill. Anyone tell me any contraindications for using Lignicaine?
I think previously somebody said allergy.
Yeah.
Nothing else coming up at the moment.
So allergy, anyone who's in complete heart block shouldn't really be using it. And if they're hypovolemic, but if they're bleeding out that much, you're not going to be faffing around and putting a ring block. You're kind of moving them somewhere else, aren't you? So the onset, it happens reasonably quickly. Does say 2 to 15 minutes. Generally, I find after about 2 or 3 minutes, they're numb and can't feel anything. Anyone tell me how long it lasts for?
Sophie's put 1 hour, Darren's put 1 hour.
Good.
And Karen's put 1 hour.
So if we read about it, it says 30 to 60 minutes. Generally, I find it lasts about an hour. So some things you should be using with caution when you're using Lignicaine. So patients who have got epilepsy, myasthenia gravis, heart failure, they're bradycardic. If they're known to have hepatic impairment, then you shouldn't really be using Lignicaine. Or at least you should be using it with caution. You might have to lower the dose. If you are doing this procedure, you need to make sure that there is resus facilities nearby. So minor injury, make sure you've got an arrest trolley nearby as well. Side effects are very rare and usually result from accidental intravesicular injection. Does anyone know anything about systemic toxicity for local anesthetic? What are the symptoms?
Nothing coming up yet, John. Ian's put numbness elsewhere, lips, tongue.
Anything else?
Darren's put tachy and Ian's put bradycardia.
So I can start off feeling a bit dizzy, lightheaded, a bit nervous, have a bit of a tremor, start getting drowsy, can go into a fit, can develop coma, respiratory failure, and cardiac arrest. It's not to scare you. These are very, very rare. But local anesthetic toxicity can start quite small and go into something very, very serious.
Yeah, Stacey's put disorientation and Ian's put rash.
Good. So local anesthetic toxicity. The patient goes into this, you are going to stop injecting straight away. You are going to get help, check their airway, give them oxygen, get IV access, You might need to think about medication to control seizures, and you might need some lipid emulsion, and you might need to have them in recess if you're in a main A&E department. Have you seen these posters in your departments? Have you ever read them?
Some people are saying no. Nope. Emma Lanson says yes. Emma, where are you from?
So
the Royal Preston.
Local anesthesia should have this up as a guideline for you. While it is very rare, you need to be aware that this can happen for anything the local anesthetic is being used for. And you should have bags of lipid emulsion in a fridge somewhere in your department. So this is the process that needs to be carried out if any of this happens to a patient. So stop, call for help, control seizures, think about bloods but don't delay anything, start CPR if necessary, and think about Intra-Lipid, which should be in your fridge.
John, some are saying this is very useful. Could it be shared as a link?
Yeah, there's a link at the very end of this.
Great.
And on the back of this, there's a second page which goes through the process that you should be doing. So there's 2 pages on this poster, and it tells you about your dosages for Intra-Lipid. Again, incredibly rare, you may never see it, but you should be aware of this. So dosing, you need to have a bolus of Intra-Lipid infusion, 1.5 mils per kilo, very quickly, over a minute, and then you'd start an infusion of 20% at 15 mils per kilo. Then reassess after 5 minutes, and you might need further boluses, and you might need to increase your infusion rate.
People are saying, John, it's also in the ALS manual, chapter 12.
Yeah. Good. So, equipment. Moving on. So, equipment do you think?
Doc.
So, one dressing pack. It's a nice clean field that you can put the finger or toe onto that you're going to be injecting.
Yeah, Darren said a syringe, a drug dressing pack.
Yeah.
And Sophie says a drawing up needle, infiltrated needle.
Yeah.
And so does Stacey. And medication. Ian says a trolley. Patients should never be sitting down for handwork procedures.
Good. So have a clean field. Make sure you've got some gloves, that you've got your syringe, that you've got 2 needles. And if you are still using glass ampules, make sure you've got a filter needle so there's no glass being drawn up. Make sure you've got some skin prep, so you're cleaning the skin before you're injecting, and that you've got proper PPE. And I would advocate having some eye protection because you're using bodily fluids, and I have seen somebody inject and have lignicaine come out the other side and go into their eye. So, procedure. Get the patient's hands or foot down on the surface. You should ideally be going into the dorsum. Skin is a little bit more thinner and a bit less sensitive. Before you do anything, make sure you're checking the sensation so that you've documented if they've got any reduced sensation from the normal sensation or if they can feel everything as normal. Then hand flat, clean the area. Make sure you've cleaned yourself as well, that you've washed your hands and you've put on your proper PPE. Check your landmarks. Draw up your medication. Insert it into the skin. So you want to be going perpendicular to the digit, needle going straight in. Aspirate, so you want to make sure that you're not in a vein or an artery. And then slowly inject about 0.5 ml to 1.5 ml while you're bringing it back out again. And you might need to re-angle a little bit as well. And then massage the area for about 30 seconds to make sure it's spreading around. And then do it on the other side. And then leave your patient. Don't go interfering with anything else, just leave them to one side. Come back to them to check for sensation, but don't start re-manipulating them straight away. Let the anesthesia get around before you do anything else to them. And it might be that you're going to relocate them at this point. It might be that you're going to send them to X-ray at this point. It might be that you're then about to go clean a wound. Okay, so these diagrams should show whereabouts you're going to be injecting into. So as you can see from the cross section, you've got nerves at the top, nerves at the bottom, and your needle goes in and fills a gap around it. And it should then give them good analgesia down the rest of that digit. Happy with that? Any questions about how you would do this procedure?
Bex has put, I always find the thumb area problematic.
Yeah. So
any tips, John?
So with the thumb, you're going to be injecting around the web space area. And you need to sometimes have a little virtual web space on the other side and inject into there. The thumb and the big toe can be a little bit more problematic and sometimes needs a little bit more, and you might need to go a little bit across the top as well, just to make sure that this is giving them good pain relief. There are other types of blocks as well that can be done around digits. So you can do metacarpal blocks further back, but I wouldn't expect that to be something from a triage nurse point of view. But for practitioners, they can do injections further back to give them more analgesic relief back here.
John, I have a question from Sophie. How do you know you're going to miss an artery or a vein underneath the structures?
So by aspirating, you'll know if you're in the right place or not.
Grabe, ang hirap naman. Artery.
So would everyone else agree with that from people who've done blocks before?
Bex is asking, John, do you have a visual of where to inject on the lateral side of the thumb?
Not in this presentation, but I can always try and Google one.
Yeah. And somebody else is asking, yeah, could you give some landmarks for MC block, and is there a volume difference?
Metacarpal blocks volume tends to be reasonably similar. I would do about 1.5 to 2 mils when I'm injecting into the metacarpal. So I'm injecting further back, it's in between the bones, and the volume is pretty similar when I inject on those. And again, check for sensation. Any other questions? Okay. So once you've done this, you'd need to be assessed to do this in practice. So on a normal study day, when I would be teaching somebody how to do blocks, I would then have a practical session and would show you how to do this. It's a little bit more tricky over a video. So what we'd recommend is you would go back into practice and you would be assessed and supervised in clinical practice doing this. Work-based assessments are a very useful tool. And the main thing for a skill would be what we call direct observation of procedural skill. So somebody who is experienced in doing this skill and is trained competent assessor would do a DOPS, would watch you in practice, and then sign you off as competent when they felt that you were ready. And then this is something that everyone could reflect upon to put back in their portfolio. Normally, what I would recommend is, if you've never done this before, is you watch somebody in practice, see how they are doing it a couple of times, and then you would try and do it under supervision several times. And then you would be assessed when you and your supervisor feel that you are ready. And then you would do a DOPS, and then you'd be signed off as competent. And at the point that you're signed off as competent, then you would be able to independently do this. So this is an example of a DOPS form. So having a form means that this is recorded. It can go into your professional portfolio. It can be kept by your practice educator in the department, as well as going into your portfolio at home. And this provides evidence to show that you have been assessed and you know what you're doing and know how to do this. And there might be some specific DOPS for your departments that have already been assessed, or we've got some forms that we are putting onto the FEN website that can be used by other departments. And it would be done step by step. So, you know, the indication, that you've got consent from the patient, that you've done all the pre-procedure checks, including allergy, that you've got all the equipment that you need, that you know where your Intra-Lipid is, that you've undertaken hygiene, you've got PPE, you've checked the patient, you've done the procedure correctly, and you've documented everything correctly in the notes as well. And then there would be some learning points made from this. So if there are things that you need to go back to do again, that will be documented. If there's any further reading that your supervisor would recommend, that will be documented on here. And then you can file this safely in your portfolio, and your practice educator could keep a copy of it as well. Do you use anything like this at present in any of your departments?
Emma Lanson says yes. Darren says no. Quite a few saying no.
So DOPS tools have come initially from medicine, and they've been used by our medical colleagues. They've been adapted when Archem brought out the ACP program, it was adapted for ACPs, and certainly in Wales for EMPs, these have been modified and used for EMPs, and now being used for qualified nurses and unqualified nurses. They've done things throughout their training for competency-based assessments. And they can be modified for any skill.
Yeah, some people say they're in the process of trying to introduce this. And Karen has put yes from Archem and ACP portfolio.
So when you put something into your portfolio, you can also add reflections on anything that you've done. So that can provide further evidence that you've reflected and done further reading. So if you've done the procedure, you've got a DOPS, you could also do reflection that you can also keep for your NMC portfolio. You can keep copies of annotated notes that we've covered in previous sessions. You can link it into any annotations that you've made from any articles that you've read. And then you can link this in the index to areas of your curriculum for your training. Does that make sense?
They're saying yes.
So from a skills point of view, this is a very short overview of how digital nerve lock would be done. Like I say, normally I would then go and do a practical session, which is a little bit more tricky on here. So I'm happy to chat through anything if anyone has any specific questions, if you want to go over any landmarking, if anyone wants to talk about their experiences of doing blocks, we can bring that up as well. And then we can go into a quiz.
Karen says, what's your thoughts on single injection block techniques?
So single injection, like injecting into the pan?
Yeah, she's put Palmer, yeah.
Okay. I'll admit I've never done it. I've seen it used in practice. It can be very, very painful for the patient from what I've seen. But it can give very good anesthesia for the finger. But personally, I've never performed it. If anyone has and has any feedback on it, feel free to share.
Ian's put, I've never been taught that, Karen, but it's supposed to be more effective to inject into the flexor tendon sheath.
Mm-hmm. Okay, shall we try a little quiz? So this works best if you are looking at this on your laptop and you've got your phone on the side. Then on your phone, either if you've got the Kahoot app already, open that, or just go to the website www.kahoot.it. So if everyone has got that.
John, there is a request for you to repeat it.
So if you go to kahoot.it on your phone, or if you've got the Kahoot app, we can open up that. Let me just turn the volume down. And when you open it, it should ask you for a PIN. Okay, shall we start? So, when was the first block first described? Well done, 5 of you were listening. And Aidan was fastest in. So next. Who can do a ring block? Who has got this within their scope of practice? Fab. And now Gav is in the lead. Is this a true or false question? Paronychia. So a paronychia is indicated for a block, but I have to admit, I've never done a block when I've had a patient with a paronychia. Because you've got a source of infection up by the nail, if you're draining a paronychia, when you're incising into the area that is infected, generally doesn't hurt the patient. And I've never done a ring block on somebody who has got a paronychia, but it is an infection. You can do one.
Samantha's asking what the pin number is, John, again.
The pin for this?
Yes, the pin to get in.
48.
I'll write it down for her, yeah.
Okay, next question. Gavin's in the... How many digital nerves are in your index finger? Well done. Does the parma nerve innervate the nail bed? Yes or no? It does. So the parma nerve runs underneath, but then it does come up into the nail bed. Lignicaine. So for dosing lignicaine, what milligram per kilogram should we be thinking about? Fab. So what's some contraindications for lignicaine this time? And they were all right. So back to local anesthetic toxicity. What's the first thing you should do if somebody is reacting? Good. So we stop the injection. That's the first thing. We make sure we stop getting any more lignicaine into them. Then we get help. If we've got a resus in our department, then we move into our resus. But we make sure everything else is sorted for that patient. But we've got to make sure that medication has been stopped. How long does lignicaine last for? Good. So up to an hour. 30 minutes to an hour. Last one. What equipment do we need? Fab. Well done. So this was a brief whistle-stop tour going through how you would perform a digital nerve block. Is there anything you want to go over again in relation to how we would undertake it and why we would do it? Anything around the medication you're not sure of?
John, there's a question from Sophie. How quick is toxicity to warrant move to recess as opposed to management where you are?
I would manage where you are. If you're in a satellite minor injury, you're going to have to manage where you are anyway. But I would start managing where you are, stop everything, get everything you need to for the patient, but it might be that you've got to get them around into recess where your lipid emulsion is. It might be that your lipid emulsion isn't in your minor injury unit. But it can happen very, very quickly. And if you're not injecting into, so if you're not, as long as you're checking you're not injecting intravascularly, then you're going to be fine. And it is very rare that this happens, but when it does, it can be very, very quick. Things will change very quickly with the patient, can get very agitated, can lose consciousness, can start seizing, can go into an arrest. But it's rare. So at this point, I'm going to stop sharing and we can open up to discussions if people want to chat about anything related to this. Or if any of my colleagues have anything else from their experience that they want to share, then we can do that as well.
Just to say, John, like you, I've never ever managed to get a proper anaesthesia when there's a paronychia, so I've stopped even trying to bother.
John, there's a question from Yvette. When injecting across the digit, how best to lift the skin? Oh, sorry.
So if you're injecting across, I wouldn't be moving the skin. The needle will go straight across, but generally you're going down for your needle placements.
And from Amanda, keep in mind that the procedure is painful when you are dealing with children.
If you're dealing with children, you want to make sure you've got distraction technique. If you've got a play specialist with you, then that's fab. If you can give them a tablet to watch, that's amazing too. Make sure they've got other analgesia on board, Calpol, Brufen. Think about other things like Entonox.
John, would you suggest anything like Hematoma or its equivalents prior to the injection?
Yeah, you can do.
Yes. That's what I've done with children, is use a topical analgesia to start with. So at least the needle going isn't so painful.
As long as it's just for a block, you can do. If it's an open wound, then
No.
if you were thinking about Lignicaine for suturing, then you wouldn't. But as long as it's just for a block.
And as one of the other people suggested, what I normally do is I get it comes in a plastic in Wales, well, in our department. I usually put it in my hand, hold it in my hand while I'm getting everything else ready, so it's warmed up prior to actually drawing it up.
Yeah, it's a lot worse if it's cold, isn't it?
Mm-hmm.
I have looked at putting it in the warming cabinet, but there's a problem with knowing how long you can leave it in there. But it's worth thinking about that, because it then comes up to a temperature that's good for the skin. And it certainly cuts down on the pain associated with the Lignicaine.
And all our
John, Sarah's asking, is the dosing for Lignicaine the same for children?
It is 3 milligrams per kilogram for kids as well, is that right, Amanda?
Yes. I believe so.
Judith, is there anything you would add from a portfolio point of view?
I mean, I can't think of anything. I know that in the session you said about the DOPS being fairly new to being used, but I think we've always had in nursing procedural skills that we've had something similar for. And I'd say that it doesn't matter how experienced you are or how long ago you were signed off. On a regular basis, it's always worth to get somebody just to come and do another check on you, so you can show your evidence is up to date. And it goes some way to meeting, certainly in the UK, the NMC registration, that you've had observed practice. And things change, don't they? And practice changes. So certainly if you haven't had an assessment for quite a while, it doesn't matter how senior you are, it's always worth redoing them. And if you do have a DOPS completed, then the value of having an annotated patient record that's been completely anonymized with it, which somebody verifies for you, that is definitely a patient that you saw and you treated, then that is hugely important and carries a lot of
to it. I think it's quite useful and important as well.
Yeah. You know, it is about making sure you make the most of every opportunity in collecting evidence, because if you do it on a regular basis, then your portfolios are always up to date and you don't have to scrabble for things when you're coming up to revalidation, or if somebody asks, how do you know you're competent to do something?
And how do you know you haven't picked up some bad habits?
Yeah. The other thing, I suppose, from a faculty point of view, is that we are starting to collate some DOPS and some mini clinical examinations. So what we'd like to do is to be able to offer those up so that individuals can use, so we're not all trying to develop the same thing. So the idea is that if anybody wants to submit any, that we can put through the educational board. They will look at them and then they will come to the FEN board for ratification. Then we've had a group of expert clinicians and educators look at those documents. so that they've got some validity for you as well. And it all means we can be doing the same thing. So that if we standardise it, we can standardise it across departments and across countries. So if anybody would like to submit them, then that would be fabulous.
Not being a EMP, could I be completely signed off with practice to be competent with, given that I won't be able to do a full neuro assessment of the hand to do like the ligaments, and I can do basic sensations and obviously, you know, kind of warm touch and all that, but not being an EMP, not being able to fully assess a hand, could I be signed off competent once I've done the actual task itself?
That's a difficult one to say, because yes, you could be signed off for doing just the procedure of doing the Lignicaine and putting it in, but why would you be doing that without doing a full assessment? Because if you're carrying out any invasive surgery or invasive suturing, you need to make sure that you've tested the function, that you haven't, and I've seen it before, where somebody has sutured a little bit too deeply and has gone into the tendon sheath, and it hasn't been recognised at the time, and it's led to an infection for the patient, and it's led to a dysfunctioning finger, for which the health board then had to pay out a great amount of money for.
So really then, unless because in the past it's been that I've had an EMP do the neurovascular assessment, they've actually done done the injecting, and then I've sutured and they tested again afterwards for me. So I'm not actually having anything to do with the digital blocking myself. So in effect, with that registered nurse point of view, the only level I'll be able to get to without being an EMP then.
What I'd say to you, Sophie, is why are you not learning? If you are carrying out the procedure, why are you not carrying out the safety checks yourself? Even though you might have to have an EMP to recheck it afterwards, I'd say it's always good practice. If I was exploring or looking at anything, I'd want to know that my practice was safe and I wasn't relying on another to come behind me to check it, because I'd want to know myself that I'd done a good job. I don't know what everybody else is feeling on that is.
Hi there. There's probably a medical legal issue there as well. I'm not sure if it's the same in the rest of the UK as it is in Scotland, but quite often we would have to maybe x-ray dislocations prior to relocating them to exclude a fracture to prove that we haven't fractured it in the procedure. I would assume you're probably fairly important to exclude any nerve injury before doing a nerve block yourself. To then avoid any legal implications afterward. Again, that's very much a Scotland view on it, so I wouldn't want to comment for the rest of the UK.
I think X-ray is an interesting one, and certainly it would depend on the mechanism of injury, and if there was a suspicion that there could be a fracture present, then yes, obviously you'd want to have an X-ray of it. But if it was a simple cut with a knife, or they'd been doing the washing up and they had a wound that had been caused by a knife in the washing up bowl, then a fracture of it would be highly unlikely.
Yeah, no, sorry, I think I was equating the reason why we maybe x-ray a dislocated finger joint, even though we're not necessarily suspicious of a fracture, but because there is a strong likelihood of fracturing during that procedure. In much the way there's probably a strong likelihood of causing a nerve injury, or a more likelihood of causing a nerve injury during a digital nerve block.
And it also, you want to see what position it's in before you start pulling anything.
Within our, sorry Judith, with our department, it's been, historically we've had nurses at triage putting ring blocks in for patient, for pain relief. They have been taught to assess the distal function, you know, in terms of nerve and circulation, but that was so that they could go to X-ray prior to having the joint reduced again. So it's not, in our department, it's not always been a full clinical examination, if you like, for that particular procedure, but that's all they're allowed to do it for in that respect.
Yeah, and there would be an expectation that they would make sure they've checked sensation beforehand.
Yeah.
And they're not doing any invasive procedure. All they're doing is injecting, and is they're doing it for the purpose of pain relief rather than for treatment, which is a very different scenario. And I would support that, because, you know, if you've got a really nasty nail bed injury, for example, you can give them as much paracetamol as you want, or ibuprofen. It's not going to have that much effect on the pain for that poor patient. And certainly it's going to be the ring block that's going to be the pain relief for that patient.
Yeah, it is.
So in that sort of situation, therefore, one would assume you could sign somebody off, as the other lady who spoke, having done that, because they are doing a certain amount of checking before they do the injection. But the procedure is actually the same, isn't it? Whether you're going to then subsequently suture anything in vein or do wound checks or whatever, it's about the procedure itself.
Well, the difference is, if you are going to do a suturing, you need to be checking that the digit after you've sutured, not expect somebody else to come behind you.
No.
It's about you doing something that's fit for you, a practice, and that is fit for that individual's practice in triage.
Yeah.
Does that help, Sophie?
Yeah, it's crossed their minds, isn't it, between trying to advance clinically when you're a certain level in the A&E department, and then also kind of not being EMP level. So I understand the litigation, and obviously I've kept my registration to this point, so I don't want to lose it now. So yeah, I'd rather be doing it right. So
it is quite an interesting one, because there's nothing set in tablets of stone of what you can and what you can't do at what level. What the NMC says is that you have to be competent to carry out whatever you are doing.
yeah.
So there's nothing that says that a band 5 can't do the treatments, or can't do a ring block and can't suture, as long as they've got the competency and skills to carry out the whole lot.
Okay.
And we've had band 5s in previous departments that I've worked in that have been trained to do this.
And you know, some of it is myth, and how that builds up, and how sometimes you've got practitioners who, they don't want to move on. They see it set in very much in tablets of stone of, well, it's only this level of nurse can carry this out, or it's only this level can. Things have moved on, because if I think back to when I started nursing and started in A&E, then, you know, we had student nurses suturing. I used to suture heads as a student nurse, you know, the scalp wounds and things. And then we went and we had expanded roles, and it was then that it was all started getting tight. And Jan, you probably remember it as well. And it used to be about what was doctors' roles and what was nursing roles. And we gradually morphed into doing more and more of what the doctors used to do.
Absolutely. And, you know, band 5s, D grades in the day, we were encouraged to do ring blocks for in triage, and also because the doctors would just abandon the patient and leave you to sew them up.
Yeah, and because we were normally better at it, because we had the longevity in the service, and we weren't there for a 3 or a 6 month stint, because it was, you didn't have the number of senior doctors around then either.
No.
From an legality point of view, probably the only thing that's restricting you doing this is if you haven't got a PDD in place, you're not a prescriber.
Yeah.
Yes.
So you need to make sure you've got something to make sure that you can document the medication appropriately. But otherwise, I can't think of anything legally that would restrict you being able to do this.
Or you've got a prescription is the other thing, that you've got a doctor or an independent prescriber to make this prescription for you. And then you would be covered.
Got a PDD for this.
And whoever's, Ian, I totally agree with you that having an EMP service has led to ED nurses being de-skilled. And we've been talking about this for some time, about how emergency nurses are losing their minor injury skills, and there seems to be a massive focus on the adult, the major side and resus side of things, and there's very little opportunity, and some of it I know has come from emergency nurse practitioners being protective and wanting to do the full episode of care, and what we've ended up with are nurses who haven't got a Scooby about how to put casts on, how to splint, how to suture, how to close wounds, because they're not exposed to it through no fault of their own. And certainly that's one of the things that we've been talking about in development of the associate nurse level competencies, and why when we are putting on the associate program, we would like the individuals who are going to partake in that program to attend all of the educational sessions, not solely on the ones that they're going to be completing a unit for getting a qualification.
Yeah, Emma's just come in saying she agrees that her ED has a similar issue. I think most have.
Yes.
I think certainly from a FEN point of view, through our webinar series, we could provide some procedural skill webinars if people are interested in them and have suggestions of things they'd like to pick up. It's a bit difficult to do some of it over the internet because you can't actually watch somebody do the skill, but that would have to be taken up locally.
I mean, the other thing, if we've got people on the call that are experienced practitioners and they're assessing in practice, then it would be great. The more that we can have joining our educational board and becoming an assessor for us, then the greater we can share the responsibility and make sure that we've got a qualification that crosses boundaries. And there's consistency.
Yeah, Vic is asking, how would we do this?
Just by emailing, you've got John's link or my link or the FEN website. Let us know you're interested, and we can have a discussion. That would be absolutely
So
fabulous.
drop it into the feedback form at the end if you want to, we can contact you.
Does everybody know about the program that we're going to start running on the 15th of September for the associate nurse level? Yes, yeah, great. And is everybody aware that on the third Thursday of every month, if you assess people, we're also going to be holding assessor workshops, so that there will be some education in that, but also a platform for individuals to share experiences and for networking. So if anybody is assessing others and would like to be a part of that, then again, that would be fabulous.
I'm just going to share my screen again to give you the QR code for the feedback form if anybody wants to. So this is the code and the web address for the feedback form for tonight's session. And if you want to get involved with other stuff, you can add that into the comments at the end as well, and we can get in touch with you. And once you've completed it, you'll get a certificate of attendance sent to your email.
Yeah.